Hi, my name is Domenica Rodriguez, and on this clip I'm going to talk about point-of-care warfarin monitoring in the Rocket AF trial. Systemic embolism and stroke are among the most important complications of trial fibrillation. The main strategy to prevent them is long-term anticoagulation, and during the last 50 years, the only available oral anticoagulants have been those derived from warfarin. In the Rocket study, anticoagulation with the factor XA antagonist rivaroxaban demonstrated clear clinical advantages in the prevention of systemic embolism and intracranial hemorrhages compared to warfarin anticoagulation, without the need for periodic anticoagulation controls.
A healthy heart works continuously to pump blood around the body by beating regularly under the control of electrical impulses that originate from the sinoatrial or SA node, the heart's natural pacemaker. These impulses radiate from the top to the bottom of the heart in a coordinated way. Each heartbeat consists of two stages where blood enters the atria, which subsequently contract, and forces blood into the ventricles. These in turn also contract, forcing blood out of the heart into the pulmonary and systemic circulations. In atrial fibrillation, electrical impulses do not originate in the sinoatrial or SA node, but from a different part of the atrium, or in the nearby pulmonary veins. These abnormal electrical signals become rapid and disorganized, radiating through the atrial walls in an uncoordinated manner. This can cause the walls of the atria to fibrillate or quiver rapidly, rather than contracting normally. Electrical signals are transmitted irregularly from the atria to the ventricles, which both fail to contract in a synchronized way. During atrial fibrillation, because the atria do not contract regularly, blood does not empty efficiently into the ventricles and begins to pool in the atria, especially in the atrial appendages. This pooling of blood can cause clots to form, which, if dislodged, can travel in the bloodstream towards the brain. The clot, or embolus, can potentially obstruct narrow blood vessels, often the middle cerebral artery or its branches, and prevent the normal flow of blood. The reduced supply of blood and oxygen to a particular part of the brain can result in tissue death, leading to ischemic stroke.
In the rivaroxaban once daily oral direct factor XA exhibition compared with vitamin K antagonism for prevention of stroke and embolism trial in atrial fibrillation, investigators found that rivaroxaban was non-inferior to warfarin in the prevention of strokes and systemic embolism in patients with atrial fibrillation. On December 2014, 4 years after completion of the trial, the Food and Drug Administration issued a recall notice for a medical device correction of the alert in ratio monitor system. It was issued because the FDA approved an European conformity point-of-care device may provide an international normalized ratio, results that is lower than automated, plasma-based laboratory INR in patients with certain and specific medical conditions, such as abnormal hematocrit levels, conditions associated with raising fibrinogen levels, and bleeding or unusual. The University of Edinburgh categorized the entire trial population according to whether patients had any recall conditions or no recall conditions, and then compared efficacy and safety outcomes with patients receiving rivaroxaban with those receiving warfarin within these subgroups.
Atrial fibrillation is a heart arrhythmia more commonly known as AFib. It's one of the supraventricular tachycardias. In a normal heart, electrical wavelets are conducted from the SA node to the AV node in an organized fashion. And since you have organized conduction going from the SA node to the AV node, you're going to get concentric or unified contraction of the atrial tissue. However, in AFib, the wavelets are in disarray, so notice how they're all erratic and going everywhere. Because you lose this organized signal, you're not going to have the unified contraction of the atria. Instead, with these erratic wavelets, you're going to have atrial spasming. So it actually kind of looks like there's a bag of worms in the atria, and they're all moving around, if you can imagine that. Also, the wavelets are doing their own thing, so they're going to be signaling the AV node erratically. And this is going to lead to an irregular rhythm because of the irregular stimulation. Classically, the AFib EKG is said to be irregularly irregular. What does that mean? Well, notice how the distance between the R intervals is different with each beat. In a normal heart, you'd see evenly spaced R intervals. But with AFib, you have different distances between the R and the R intervals. Also in AFib, there are no distinct P waves on EKG. Instead, you have these coarse, squiggly lines running through. But there are no distinct P waves. That's because, remember, the atria is spasming. So you're not going to get that nice, unified, concentric contraction of the atria. So you have these coarse, squiggly lines instead, representing the atrial spasm. What are the risk factors for atrial fibrillation? Well, anyone who has diseased atrial tissue has an increased risk for AFib. And how does atrial tissue become diseased? Well, with old age. So the skin in your body tends to get old with age. So does your atrial tissue. Also, anything that causes the tissue of the atria become inflamed can cause atrial fibrillation. So imagine if you just had a recent heart procedure that caused inflammation. That will increase your risk for atrial fibrillation. And anything that causes atrial enlargement. So this includes years of high blood pressure, and also certain types of valve disease, like mitral stenosis, certain types of lung disease, and previously having AFib can enlarge your atria. Other things that increase your risk include certain hormonal abnormalities, specifically your thyroid hormone, and years of alcohol abuse. It's also worth mentioning that people who have AFib are at an increased risk for having strokes. So these people are typically put on some sort of blood thinner medication. Now, why are these people at a higher risk for stroke? When the atria is spasming, blood's going to pool in the atrium. When the atrial tissue is spasming, blood then pools in the atria, and it doesn't move. And what happens to blood that doesn't move? It clots. Now imagine, so I'm drawing a big clot right here. And imagine if this clot escaped the atrium, went to the ventricle, and then out to the rest of the circulation. It can go to other organs, including the brain. And if the clot goes to a blood vessel that supplies the brain, well, that can lead to stroke. Therefore, people who've had AFib are usually put on blood thinners, which will help prevent clot formation and thereby reduce the risk of certain kinds of strokes.
In the analysis, they first compared the relative effect of rivaroxaban versus warfarin on measured efficacy in the overall trial population and in patients with no recall conditions. Second, they compared the relative effect of rivaroxaban versus warfarin on measured efficacy and safety outcomes in patients with any recall condition. Third, they perform a sensitivity analysis in which patients with possible acute onset recall conditions were included in the subgroups of patients with no recall condition until the time of onset of the acute condition. And fourth, they evaluated the primary efficacy endpoint in the intention to treat and per protocol population to present results consistent with those in the primary trial report.
5 times more at risk of a stroke and 3 times more at risk of developing congestive heart failure than someone without AF. Furthermore, AF-related strokes are often more serious and disabling than non-AF-related strokes. Therefore, stroke prevention in patients with AF is of critical importance. Effective anticoagulation reduces the risk of stroke. Until recently, vitamin K antagonists such as warfarin were the therapy of choice, but were associated with some limitations, such as the need for routine coagulation monitoring, increased drug-drug interactions, and dietary restrictions. Guidelines in the EU and the US now recommend the use of novel direct oral anticoagulants such as rivaroxaban, apixaban, dabigatran, and edoxaban in preference to vitamin K antagonists for stroke reduction in patients with AF. This review focuses on the direct factor X inhibitor rivaroxaban. Rivaroxaban 20 milligrams once daily is approved in the EU, the US, and Canada for the prevention of stroke and systemic embolism in patients with non-valvular atrial fibrillation and one or more risk factors, including congestive heart failure, hypertension, age 75 years or older, diabetes mellitus, or prior stroke or transient ischemic attack.
Conclusion. The results showed non-inferior of rivaroxaban versus warfarin for preventing strokes and systemic embolism, with similar rates of overall bleeding. These results are consistent with the overall trial findings and indicate that possible malfunction of the point-of-care device used for INR measurement in the Rocket AF trial that but these results are consistent with the overall trial findings. These results are consistent with the overall trial findings and indicate that possible malfunction of the point-of-care device used for INR measurement in the Rocket AF trial that potentially led to lower INR values than would be obtained by laboratory tests. Laboratory testing did not. These results are consistent with the overall trial findings and indicate that possible malfunction of the point-of-care device used for INR measurement in the Rocket AF trial that potentially led to lower INR values that would be obtained by laboratory testing did not have any significant clinical effect on the primary efficacy and safety outcomes of the trial.